Thank you, Ms. Scott. And now we'll have our final panelist, Dr. Lisa Puglisi.
Okay. Good morning. Thank you for the opportunity to be here to speak with you today. I'm a physician. I practice general internal medicine at Yale, and I have a focus on care for patients with histories of incarceration through my involvement with the Transitions Clinic Network. We are a network of providers based on the principles of providing rapid access to care within 2 weeks of release in community health centers with providers who are culturally competent and trained, community health workers who themselves have histories of incarceration, and close ties with social organizations in each community which address social determinants of health. So I want to make this conversation personal. These are patients who I see. This is one gentleman from one of our clinics, but typical patient who I see, 55-year-old gentleman, history of diabetes, hypertension, depression, and opiate use disorder, released from prison a week prior, lifetime heroin use since he was a teenager, in treatment once a long time ago, and none recently. Coming into established care. He has had 5 lifetime prior incarcerations. And what I know, though I'm seeing him in a community health center, is that, next slide, this is where he's accessed most of the health care in his life. I'm going to draw your attention to the built space, segregation of people, the really impersonal nature of care. The blood pressure machine is outside of a caged-in area, right? The size of the facility and the presence of law enforcement just down the hall. So we know that for some, health care received while incarcerated along with a change in environment is actually life-saving. But it also is in a facility which is built to punish, not built to treat illness. We know that the harsh and socially isolating conditions inside actually exacerbate mental illness, and especially for those who are exposed to solitary confinement. So we've heard a lot of statistics this morning, but about 10 to 15% of people in state prisons have a diagnosed severe mental illness, but up to 50% have symptoms of a psychiatric illness. And we know that over 50% have diagnosable substance use disorder. However, only less than a quarter of those in state prisons and less than 10% of those in jail will be treated for these conditions while incarcerated. So given the 10 million people who pass through the criminal justice system yearly, most of whom are returning home, you can see that the burden of onus on treatment for physical and mental health illness is immense. This treatment period is not only a difficult period on a personal level, but it's a dangerous period associated with a 12 times increased risk of death in the 2 weeks post-discharge, mostly from overdose. So, up to this point, there has really never been a nationally coordinated effort to address and try to mitigate these risks, aside from the work that we do at Transitions Clinic. Can you go to the next slide, please? We are actually the next one after that, thank you. We are a group, a network of health providers in 16 locations in 6 states in Puerto Rico, but we are based really around use of community health workers to help implement care. Community health workers are, by definition, people from the community, people with shared social and socioeconomic backgrounds, demographic backgrounds, shared life experiences, and what we see to be the really singularly unifying experience, which is that of having been incarcerated. It is the experience above all others that changes people's life forever, changes access to housing, financial assistance, food stamps, employment opportunities, and changes their health outcomes. So we use community health workers as a way to not only help people access care, which is important and necessary, but not enough, because we know that through long social traditions and past histories, there is a distrust often of the healthcare system, which leads people to really not engage in healthcare. And community health workers can serve as that link to help people find a connection, understand what's going on, and feel that it's something accessible and that they can utilize. Next slide, please. I'd like to show you the demographics of the people who we see in our clinics. So you'll note that they're disproportionately non-Caucasian, mostly non-Caucasian. Unlike the general post-incarceration population, they're a bit older because we focus on medical illness. So where the general population in the mid-30s, we're seeing older patients. You'll note that a third have completed less than a high school education. Most of them are housing insecure. And 50% have a substance dependence and psychiatric condition. But this is probably a really gross underestimate, because we've recently gotten data from our state that actually just about 90% of our patients have had lifetime involvement with the Department of Mental Health Services in our state. You can go to the next slide, please. Okay, thank you. So what we see is that through utilizing we have actually, randomized control clinical trial data that shows that enrollment in Transitions Clinic Network Center compared to expedited primary care, so the difference in transitions being a community health worker, leads to decreased ED utilization. And you can see that here. This is not from the randomized trial, but this is from a different look at our data. But people post-engagement in TCN, there's a dramatic decline over that next year in ED and in this case, hospital utilization. So let's return to our patient. What do we do for him? What is the ideal? How do you care for this gentleman and affect his life? So next slide, please. The gentleman there in the black hat is Jerry Smart Jr., who is the community health worker who I work directly with. So Jerry, in some cases, goes into jail or prison and engages that person before release. In an ideal world, that person, our patient, would have already been started on treatment for substance use disorder. That doesn't happen very frequently, but he's engaging them inside. If he's not able to engage him inside, he's meeting with them in the community immediately upon release, within a few days. He's finding out, who are they? What is their life like? What are their concerns? He realizes that our patient actually only really cares at this time that he doesn't have an ID. He can't seem to accomplish much without having an ID. So Jerry helps him get an ID. He knows how to, and it's not very hard for him to do. But he's also trained about substance use disorder, trained to recognize symptoms of cravings and risk of relapse. So he identifies this off the bat. It's all the guy can think about, and helps counsel him. Helps him understand the importance of coming to his first visit with us, accompanies him to the first visit, helps him understand what we're talking about, and we talk about relapse prevention. I educate him about his health risks, having been incarcerated, risks related to substance use, and of course diabetes, hypertension, and all the other stuff. But on that first visit, he's given a naloxone injector and educated how to talk to his family about how to use it in the advent of an overdose. Within 2 weeks, he started on buprenorphine treatment. I'm treating his substance use disorder to prevent relapse, not let the horse come out of the barn. So we're preventing relapse. His cravings are controlled enough that he can be present for his children who he hasn't seen, grandchildren who he has to build relationships with, and he can start a job search. So, in summary, I feel really strongly that a trained workforce of community health workers is going to be crucial to the success of CCBHCs in accomplishing comprehensive patient care under a prospective payment model. And I strongly encourage the 24 states that have been given planning grants to really consider utilizing this crucial workforce to help achieve that goal.